Okay, students, this is your last lecture on the GI system. We're going to cover the liver, gallbladder, pancreas, and spleen. So with gallbladder pathology, we're going to be looking at gallstones, acute cholecystitis, emphysematous cholecystitis, and we have porcelain gallbladder. So with the gallstones, there's two major types. There's cholesterol and pigment. So cholesterol is the most predominant here in the United States, and it causes a big challenge because they're radiolucent. So some of the things that predisposes you to having gallstones is, of course, a family history, being over the age of 40, being overweight, and being female. So ultrasound is the best modality, as in x-ray, most of the time they're radiolucent, so we can't see them. So here you can see these are all gallstones. This is in the gallbladder, and they have a calcified ring to them. So the middle is radiolucent, but the outside we can see. So you can see them here and in here. So these are gallstones. It's hard when they're overlying the spine. So sometimes you have to roll them up a little bit, do a little bit of an oblique to be able to see all the gallstones. This is ultrasound, so this is the gallbladder here, and you've got a stone right here, and we know that this is a stone because we have shadowing. So this is shadowing from the stone. And acute cholecystitis, so it's an inflammation of the gallbladder. It's usually caused by cystic duct obstruction, so by a gallstone. And the imaging modalities that we want to use is ultrasound or nuclear medicine. So if we look here, this is an engorged gallbladder right here on nuclear medicine. Then they inject CCK and it emptied normally. So this is how they take a look using nuclear medicine. So emphysematous cystitis, cholecystitis, so is a rare condition that occurs when stasis, ischemia, and cystic duct obstructions, so such as stones, allow gas to grow within the gallbladder. So it occurs more commonly in elderly men who have out of control diabetes, so poorly controlled diabetes mellitus. So what we're looking for on a KUB is we want to see if there's gas within the gallbladder. So when you take an image, this is of course blown up, so you don't see the full KUB, but you can see the gallbladder here, and you have sludge, so we call this sludge, and then you have air within the gallbladder. So that's a telltale sign that we have a problem here. Porcelain gallbladder refers to calcification of the gallbladder wall. So it looks like an egg. It is caused by chronic cholecystitis, and the walls become fibrous and then they calcify. So the imaging is broad continuous bands, and the bands turn into calcification, so you can see that, and the muscle layers of the gallbladder. So when we see this, the one thing that we need to do is make sure it's not cancerous. So here is a picture of a porcelain gallbladder right here, and this is a KUB where you can see a porcelain gallbladder. So this looks more like an egg. So that's what we're looking for there, and like I said, we just need to rule out any kind of cancer with that. So here are your disorder summary of your gallbladder. We're going to roll right into the liver. We're going to look at hepatitis, cirrhosis of the liver, hepatocellular carcinoma, and hepatic metastasis. Hepatitis, so most prevalent inflammatory disease of the liver. Can be caused from viral infections or reaction to drugs or toxins, and as you know, the different types are A, B, C, and E. And hepatitis B is what we're concerned with as healthcare workers. It's transmitted through contaminated blood and blood products and sexual contact. So there is a vaccine available, and yes, it is required for employment. So cirrhosis. It's a chronic destruction of liver cells and structure with nodular regeneration of liver parenchyma and fibrosis. So it's an end-stage liver disease. The major cause is usually alcoholism. So we're talking about 10 to 20 years of alcohol abuse can cause this. Fibrous connective tissue replaces the destroyed liver cells with cells that have no liver function. So the liver basically is being replaced with these fibrous cells that make it so it's real stiff and it doesn't function. So this is why we call it the end stage liver disease. It can be from viral hepatitis, from drugs and chemicals, and biliary cirrhosis also. So hematochromatosis also. The one thing that you're going to see with patients that have cirrhosis of the liver is ascites in the abdomen. So they're going to have big, round, hard abdomens. This is incurable and irreversible. So what we're going to be seeing with the alcoholic cirrhosis is a large amount of fat within the liver, and I'm going to show you what that looks like, and throughout the PowerPoint I'll point out the differences between the liver and the spleen, because we use the spleen as a baseline for the density. So I'll show you what I'm talking about here in just a minute. You're going to see fluid accumulation in the abdomen, and typically you're going to see enlarged breasts on men and women due to a female hormone secretion due to the damage. So here is a CT scan. So we have what we call fatty infiltrates in the liver. So here is the liver. So one, the liver is enlarged, so the liver is larger than it normally is. And you can see how dark the liver is. And here's the spleen. So this is the spleen. This is the stomach right here. So you can see the density of the spleen. That is the density that the liver is supposed to be. So you see how dark it is and how bright the spleen is. These should be isodense, so the same density. So this is fatty replaced liver in liver cirrhosis. So hepatocellular carcinoma goes after your cirrhosis. So it's a primary liver cell cancer, most common those with cirrhosis. So not always, but it is more common with cirrhosis. And CT is really your modality of choice. When we're looking here, here's your spleen, here's your pancreas, and your stomach is up here. This is your liver right here. So you have right kidney, left kidney. Here is your liver. And as you can see, this area right here is your mass. So this is hepatocellular carcinoma. So this is not good. And I'll show you the difference between the hepatocellular carcinoma and metastasis to the liver. So it looks different. So you know that this is a primary tumor. And you can see the margin right here of healthy liver. So this is your pancreas. This is your tail, because it's right by the spleen. This is a pseudocyst. It's an incidental finding that they have. Here's your stomach. Normally your stomach is in this area, but it's being displaced by the pseudocyst. So hepatic metastasis is the most common malignancy of the liver. A lot of times when you have cancers, the liver filters out any toxins within your body, and the cancer cells will go to the liver. So once it hits the liver, your prognosis is pretty poor. CT is a great way to diagnose your metastasis. So as you recall, we had a big, huge mass on the prior slide of the primary liver cancer. So this is metastasis. So you can see here all these patches. All these patches are metastasis. So this is pretty bad. Here on ultrasound, you can see all these little defects. All these defects are metastasis. So pretty sad. Here is your summary for your liver. So make sure you take a look at that. Now we're going to cover the pancreas. We have acute pancreatitis, chronic pancreatitis, pancreatic pseudocyst, and cancer of the pancreas. So with acute pancreatitis, it's an inflammatory process in which protein and lipid digestion enzymes become activated within the pancreas and begin to digest the organ itself, which is crazy. So most common cause, excessive alcohol consumption. Other causes, so gallbladder obstructing the bile flow. So it can you can get acute pancreatitis from a gallstone. X-rays typically appear normal, so we're going to use CT and ultrasound to diagnose the acute pancreatitis. You can see here, this is the pancreas, and normally it's not as fat as this, and you can see little notches within it. This is a very angry, what I call angry pancreas, and you can see all of this is called this is all fluid, and the little lines outside of that is called stranding. It's a sign of infection. So all this is infected tissue. So this is all components here within the pancreas that's given us the acute pancreatitis. And then all these white little lines is called stranding, which tells us that that is an infection. And then here, this is what it looks like on ultrasound when it's all inflamed. So chronic pancreatitis results when frequent injury to the pancreas causes scar tissue. So recurrent episodes usually result from chronic alcohol abuse, but it can be from stones too. It causes the gland to lose its ability to produce digestive enzymes, insulin, and glucagon. So the three symptoms are pain, malabsorption, causing weight loss, and diabetes. And typically with chronic pancreatitis, you're going to get these pancreatic calcifications. So you can see all these little dots. That is your pancreas with the calcifications within it. So that's a sign of chronic pancreatitis. So pancreatic cirrhosis, you've already seen one. So it's defined as a walled-off fluid collection. They occur due to inflammation, necrosis, and hemorrhage. So some of the causes are acute pancreatitis and trauma. So you can see here, this is walled off right here. So you rule this out from a porcelain gallbladder based on the location. Okay, so here's a CT, and you can see the pseudocysts. There's 4 within this pancreatic. It's like, ouch, that doesn't look nice. So cancer of the pancreas, oh my gosh. So it's the most common type of cancer of the pancreas is adenocarcinoma, adencarcinoma, sorry. Usually advanced by the time we diagnose it, and it's usually poor. You can't live without your pancreas, so we can't remove it per se. So it's really, really tough to treat. Most common site is the head of the pancreas, and there are other types of tumors also. So you can see here in the head, we've got a tumor within the pancreas, so that's pretty sad. Here's a CT, and you can see this big mass right here, and that is in the pancreatic head. And you can see it, contrast enhancement, you can see that there's a tumor within that. The one thing I wanted to show you is the ring enhancement here. It looks like a porcelain gallbladder, but just incidental there. Here is your summary of findings for the pancreas. Now, pneumoperitoneum, didn't want to come out. So that is defined as free air in the peritoneal cavity. So it's usually from perforation of gas-containing viscus, so it's typically a surgical emergency, but there is a case where it's not, or cases. So the abdomen, gynecological, intrathoracic causes, they're not a surgical emergency and don't require operative intervention. You need to get a good history so that you can tell the radiologist what's going on. This is what it looks like. It's just free air under the diaphragm. So we've seen this before. It's really important that you get a horizontal beam with the patient all the way up. If not, you need to do a decube. Okay, so let's go into the spleen. We have the enlargement and the rupture. So splenomegaly is enlargement of the spleen, is associated with numerous conditions from infection. It can be subacute bacterial endocarditis, TB, mono, malaria. It's a connective tissue disorder, so neoplastic hematological disorder, so it also can be like a lymphoma or leukemia that can cause it, hemolytic anemia, and cirrhosis also. So here is your spleen on CT. And remember how I talked about on the cirrhosis of the liver? So here is your spleen right here, and it's definitely enlarged. It's normally not this size, but you can see that the spleen and the liver are isodense, what we call isodense. They're the same density. So that's what the cirrhosis liver is supposed to look like, is this, and not really dark like it was. So this patient has splenomegaly, and the doctor will find out the cause. So splenic rupture, most common cause of splenic rupture is trauma. So the problem is a rapid blood loss, so you need to do surgery right away or you can bleed to death. It can be a complication from a palpation of a spleen that's enlarged by infection, so like mono or leukemia. So when a kid has mono, we always do an x-ray, well, not always, but usually do an x-ray to take a look at the size of their spleen. Especially if they're an athlete, they're not allowed to have any kind of contact sport if they have mono with an enlarged spleen, because it can rupture. All right, so this is CT, and you can see the spleen right here. This person was in an MBA, and it has a splenic rupture, so you can see contrast within the stomach, and all of this is blood components. So this person has a ruptured spleen and needs to have surgery to have the spleen removed. You can live without your spleen. So here's your liver right here. So here's your summary of disorders for your spleen, and that should be wrapping it up, and I'll post your quiz for you.